So given the science that's indicating that exercise increases inflammation, strengthening exercises should be delayed until inflammation has been effectively controlled to avoid worsening of arthrofibrosis. So Othmar, what signs or tests do you use to determine when it's safe to transition from inflammation control to muscle strengthening in your patients?
There is no certain test. It's feeling. It's hard to explain. Really a good question. It's more or less feeling when I see the patient is on a point where we can improve strengthening exercises. The start always is with the most natural movement patterns, which means standing up, sitting down, and walking, and all the with a focus on the eccentric and not concentric. One of the biggest problems in all physiotherapy, in my opinion, is the eccentric motion and not the concentric. Normally, we get the problem in over-concentric, and too little eccentric is the same as, from skiing. The relaxed skier has a good eccentric, and the forced skier is over-concentric, which makes the skier stiff. And I try to go the same approach in the therapy, and the letting. Should I explain? It's not the active letting loose, giving loose, is a major goal, and then I can play with the body weight in different position, different heights, sitting heights, and that's the way I want to get slowly to real strengthening exercises. Sitting down, standing up is not more, not less than a squat. But I can adapt it very, very easily on the point the patient is. And from there, I get closer to real strengthening exercises. I avoid machine exercises as much as I can, because I try to get the original movement patterns to activate the old patterns we all have in us, and the pathology brings them in the background. I want to bring the old patterns in front, in the pole position. Okay. That's my approach.
Thank you. So unfortunately, despite the patient's best efforts, arthrofibrosis can progress due to its underlying pathological mechanisms. So blaming patients for the condition can be very counterproductive. Jamie, how do you support encourage patients who are following their exercise programs but still experience progression of arthrofibrosis?
Yeah, this is definitely a tough position for a patient to get into when they feel like they're doing everything that they are supposed to and still not seeing the progress that they hope to see. I think that something that can help a lot of people and that I do is by letting them know that they're not alone. This does happen to other people, unfortunately, but I think just knowing that you're not alone and there is a community such as this to reach out to or to refer to can help patients recognize that they are not alone. It can help staunch any feelings of hopelessness that they might have that could progress further. And then I think both Sebastiano and Othmar talked about the other aspects of the patient's life. just outside of their leg or their shoulder, whatever they're healing from, but being sure to have them focus on those areas as well, because I think that when you're focusing on exercises and it's not getting better, you can focus on them even more and then forget about the other important things in their life. And so just making sure to check in on the other roles that they play as a family member of their community, to make sure that they are once again getting support from those areas. Another thing from just like an exercise standpoint is, as long as the exercises are not painful, I still encourage them to continue to perform them, because even though they're not making progress, if we stop with the beneficial movement, sometimes we can see a reversal. And so focusing, when I'm telling them that, focusing on what has improved thus far and encouraging them to continue so we don't lose those improvements. But yeah, those are some of the things that I've found helpful. Depending on the person, I think focusing on like a mindfulness exercise or mindfulness therapy can be helpful. For some people, it's even taking a few days or a week off of their rehab program to go once again enjoy the other parts of their life, and then can come back with a new focus to what can be done to continue to progress along their course of rehab.
Yeah. Sebastiano, you wanted to respond?
Very quickly, I just wanted to say that I think we should try to destigmatize the role of a psychologist here. In the end, we are physical therapists, and I know we want to help patients, but that we might not be equipped with the skills to do so. So I'm not saying we are not. I think we, sometimes I was sitting this morning in a clinic. We had patients from different countries with arthrofibrosis all around me. I think physios were doing a great job, and it was mostly supporting them. But I mean, this is a long-term process, and we've been discussing a lot with our surgical team to methodically, so make it happen, involve a psychologist or a psychological coach. You can call it the way you want it, but someone that is skilled enough to not being perceived as I don't want to say as a threat, but when you say to a patient, hey, listen, now you have a knee problem, but I would like you to see a psychologist, in a second the patient thinks, oh, so you think I'm crazy. So that's again another one not believing me. And again, I think the process is as good as we present that to the patient. So we need to be better in presenting the option as a support factor to the patient and say, hey, listen, I might not be good enough in this, so I'm trying to do my best, but I think you might benefit of this, you or the caregivers. It might be your husband or your wife. I mean, this thing is tough. It's heavy on you. One point, and the other point is what I used to call the clinician deal. When we train new physios with this, or when we run any arthrofibrosis course, there is one moment in which we say, hey, we need to be prepared to fail. We're not trained to do so. As physios, that's the pathology, that's what I have to do. Recovery will happen sooner or later. Also, we will fail, not just the patient. So we need to be ready to know that with these patients, we might not succeed. Accept the option, accept the possibility. And because it might be that we are the ones not fully accepting the fact that the pathology is not evolving as we like. And in this case, we might not offer a decent support or the best possible support to patients. And I think
let's hear what Jamie has to say.
Yeah, it's just a quick addition or to go off of what Sebastiano was saying. If a lot of these people are athletes, especially if they've had a ligament injury, I've always liked to use the team and the multiple coaches analogy. So any team sport has multiple coaches on it, and they all provide different aspects of the coaching. Different benefits come from each of them, and so I found that bringing in a psychologist or some sort of a mental health coach, and relating that to needing a team to help them get the best results has been helpful and kind of easier to understand, to also like destigmatize the use of a psychologist or a mental health coach.
Excellent. Yeah, maybe it won't heal the knee, but at least it will make the quality of life much better. Yeah. So pain is also a critical indicator of inflammation and tissue damage in arthrofibrosis, and pushing through it can lead to worsening of the symptoms. Jamie has talked about not pushing through the pain already. But Sebastiano, how do you help patients understand the difference between beneficial discomfort and harmful pain? And how do you adjust treatment when pain levels increase?
I think this is crucial. We have to realize, like in life, that we are dealing with different personalities, different people. So some of them are overachievers. They wanna get there no matter what. So if you tell me that I have to tolerate some level of pain, I will. And then for them, tolerable pain can be 8 out of 10, because for them it's tolerable, but it could be harmful in the end. So what we try to do is we don't want to give numbers, even if it's probably the best approach, but ask patients, tell patients, hey, do you understand what 4 out of 10 is? And 90% of the patient will say, oh, I have no idea what you're talking about. So what I would say is, anyway, discomfort versus pain, that's what we try to educate patients on. Should be something that you don't like, but it's not painful. We need to have some level of tissue stress to determine, as a stimulus, to determine a tissue adaptation. In the end, it's always the same principle. But if it is too much, we will get, so it's painful, we will get an adaptation, but also of the nervous system, which means we might sensitize it. We might, let's say, make a couple of steps forward to then find ourselves 10, 20, 30 steps backwards. So I would say we go with a 0 to, use the number you want to rule, could be 0 to 2 or 0 to 4, but let's say discomfort. What we say is, hey, 0 to 3 is discomfort. Above that, it's pain. Whatever 3 is for you, and that's the rule. Go with that. And at the same time, monitor, as Jamie was saying correctly before, I believe, monitor what happens in terms of the severity of pain. So what happens in the following 24 or 48 hours? Usually 24 hours is enough. This is not bone edema. This is, anyway, soft tissues. They're not as softy as they used to be. They're fibrotic. But anyway, if the knee says to you, back to you, that's not happy, that's it. And I don't feel it. So what we try to tell patient is, you are in charge. I have no idea. I don't feel your pain. And I will never, ever think you're lying to me. So if you come back in the clinic the following day and says, even if that was a little step, we just did a little bit more than the day before, that was worse, we step backward, we regress. So we need to, I think we are very good in training patients how to progress. We need to train them how to regress, especially because they have to carry on a home exercise program. So again, load reduction. And again, as a general rule, what was that we did yesterday? We did, let's say 5, whatever it is. We have regressed by a couple of sessions. So the day before it was 4. Now we come back to 3. We want to make sure what we do today, it is not 0. We don't skip PT. We provide some stimulus. You might bike if that was with no resistance, if that was done the week before, for instance. We try to still do this. And if, again, you have no reaction the following 1-2 days, then we can progress again. But yeah, I would say that's, empirically speaking, the way we progress throughout this.
Thank you. Yeah. So massage of surrounding muscles, so rather than the joint itself, is believed to aid in increasing lymph flow, removing inflammatory cytokines, and reducing hypoxia, at least in the short term. So Othmar, how do you incorporate muscle massage and lymph drainage into your treatment plan?
It's one of the, especially in the start of the therapy, one of the major parts. It helps to calm down the system. I wouldn't name it muscle massage or only lymph drainage or whatever. It's a kind of micro mobilization in the tissues where you can feel, it's kind of osteopathic approach. You can feel that the system calms down, and all the patients give the feedback that after the session it feels easier, better, less pain, and the more often we do the treatment, the more stable the effect stays. So in my opinion, the manual approach is very important in the first phase of arthrofibrosis. So I don't go along with the hands-off approach, which is forced a lot in Germany, and exercise, and more and more and more. So it's very, very light. It's a big mixture of massage, lymph drainage, osteopathic approach, whatever. It's also a lot of feeling, but very important in my opinion.
Thank you. And maintaining overall physical health by exercising non-affected parts of the body is possibly also important, as it can help prevent deconditioning while protecting the affected joint. Jamie, what types of exercises do you typically recommend to maintain general fitness without risking the affected joint? Oh, you're still muted.
It depends on what amount of or what the intensity of their irritation or irritability is. As far as like, is it a systemic irritation or inflammation that's leading to this arthrofibrosis, or is it more of a local, down to a local effect? So as far as types of exercises, I think we have the equipment now that for aerobic exercise, we can easily offload the affected joint, whether like with a fan bike, where they can set their leg up on a peg, or their affected leg on a peg, and then work the other 3 limbs and still be able to get a cardio effect to get the heart rate elevated. Same thing if it was a shoulder fibrosis, we could go with 1 arm and 2 legs to get a similar effect. Always checking in on the pain scales that I talked about, that Sebastiano talked about, as well as how they are feeling the next day, to continue to adjust how intensely we can program that. And then as far as the other aspect of general health guidelines of strength training, I think we can definitely strength train around the affected limb or joint as well. We see that there's some cross-training effects from training the non-involved side, as well as if they're far enough along where they're not in an active inflammation or active irritation, even strengthening through a pain-free range of motion on the affected limb could be helpful. With all of the strengthening exercises, definitely not going to a 1 rep maximum or to 100% capacity. So what I found to be helpful is staying at about a 3 to 4 rep maximum, or a 7 out of 10 of intensity, for still getting the training benefits without overstressing the entire body to limit any further irritation or inflammation of the arthrofibrosis aspect.
Thank you. So in the experience of the IAA, using regular pain-free continuous passive motion, so CPM for short, or passive stretching can help maintain joint mobility, and research indicates that cyclic stretch can reduce adhesions and inflammation. So Sebastiano, when do you introduce CPM or passive stretching into a patient's treatment plan, and how do you monitor for potential adverse effects?
So if we are referring to CPM itself as a device, I think we need to divide the patients into post-op and chronic patients. Post-op, they wake up after surgery into the CPM. So our protocol is And again, we operated on a patient this morning. So the patient woke up in the CPM when anesthesia faded off. We want them to be up to 8 to 12 hours per day in the CPM, not continuously, obviously, so that we sort of encourage these patients in sleeping into the CPM overnight if they can. Obviously, they don't have to disrupt sleeping. Otherwise, we have another problem because we impact healing. They have to sleep. Otherwise, if they lack sleep, we search for a benefit on one side and then it doesn't pay off on another side. But the point is, again, we need to sort of being objective here. When they are surgical patients, and we never want to have these patients lying on the operative table again. But if PT is not progressing, it might happen. So in the end, scar tissues will form back. Adhesions will try to happen again. Simply, body doesn't accept cavities. So as soon as they are out of the OR, the scar tissues will start forming, and they will form. So we want to have them with their knee moving as low as possible in a comfortable way, because this way at least we try to have the tissues and let's say the layer of the capsule, different area of the capsule or just the medial lateral gutters not to adhere again and scar down again. And it's not certain. They cannot get for sure benefit out of it, but it's believed to help. So let's say to answer to your question, it is right away post-op. Instead, if they are chronic patients, we rarely use CPM, to be honest with you, because it's there is no force into it. So the CPM is accompanying you throughout the movement, which you need to have by yourself because you have no pain. That's why you have nerve blocks post-op, because if you have pain, you don't bend your knee. Hence, you will fight the CPM, and the CPM has no power to actually progress you throughout flexion. You will just win resisting. Hence, if you again we see a patient in our clinic, and let's say it's 6 months post whatever after the onset of the arthrofibrosis, we're dealing with stiffness. We need to go with another approach. CPM is not going to be enough, or anyways, it's not the right approach. And again, that's when LLPS, low load prolonged stretch, and all the other things we talked about in this interview, they kick in.
So to prevent further injury to a healing joint, especially inflamed fat pads, non-weight bearing is often recommended immediately after surgery, with gradual reintroduction of weight bearing as tolerated. Othmar, what criteria do you use to determine when it's safe for a patient to progress from non-weight bearing to partial weight bearing activities?
Normally, after surgery, the medical doctor says weight bearing, yes, no, and how much and how long. So normally we discuss it, how long it's necessary, from when the structure tolerates the weight, and when this is, I got the okay from the medical doctor, from the surgeon. It depends. I start to partly weight bearing as soon as possible, because the non-weight bearing increases the muscle tonus, especially in the quadriceps, because the patients tend to carry the whole leg, and it gets really, really hard. And if they are able to do a partly weight bearing with the sticks in a good movement pattern, they can relax in every step. I recommend very small steps and as much using the sticks as necessary, but as less as possible. If the weight bearing increases pain, it has to get less. And I always say the bill is done the next day. So if you have a good feeling today, the real effect is seen on the next day, because sometimes the next day is worse. And so I try to explain the patients to be patient and not to force, even they get a good feeling, because it can go the wrong way. We try to keep the ball flat the next day. If it's really good, stay the same level, and then maybe improve. But yeah, that's the approach, to bring as much as possible, but as little as necessary.
Yeah. Sebastiano, you mentioned before that you wouldn't mind having patients, arthrofibrosis patients, non-weight bearing for 6 weeks, I guess. You're still muted?
Yeah, no, actually, I'm absolutely in line with what Othmar said. I just want to add on top of this, partial weight bearing, yes, obviously. So it's just a fine, it's a dance, really. We go with what we see day by day. But I think that Othmar raised a great point on we need to wait what happens and understand how the knee reacted the following day, even 2-3 days afterwards. Patients do judge within 10 minutes. Oh, I walked with one crutch for a block. Nothing happens. Good. I'm going to walk for another block. And then the results of it piles up. And then the following day, your knee is a balloon, which for a normal knee is just an acute phase. For your knee, it might be a disaster if you have knee arthrofibrosis. So the thing I want to point out is we had so many cases of patients that, regardless the education, regardless how many times we told them, hey, listen, don't forget, things are getting better. Yes, you're getting out of the problem. We can see that. And now you're off crutches, but it doesn't mean you go hiking, right? So just go with a slow, steady progression. And then all of a sudden, what they did was just standing with friends for 3 hours, drinking beers, standing, gravity, right? If they are post-op patients, gravity is a killer. Alcohol is a vasodilator, so you can have all these effects combined, and then the following day or 2 days afterwards, the knee was much worse, and they had to start over from 3 weeks, 4 weeks before, or they triggered again the whole thing. So the only thing I want to point out is arthrofibrosis is not a normal condition. You might trigger the whole thing again if you behave in a way that is say too aggressive. So we really need to stress these patients. It's not easy. We do this. I think we all do this. And then all of a sudden our patients come back and say, I don't know what happened. My knee is much worse. And then you investigate and ask them, and they have done too much in a little amount of time, which is a problem.
Yeah. And I think maybe also cycling is one of those topics. So it's often recommended as a low impact exercise for maintaining joint mobility and overall fitness. However, especially in arthrofibrosis patients, there are cases where cycling has made it worse due to the stress on areas like the shortened patellar tendon and the scarred Hoffa's fat pad.
True.
So, Jamie, given that cycling can sometimes worsen arthrofibrosis by stressing the anterior knee, how do you decide when cycling is appropriate for patients, and what modifications or precautions do you implement to ensure that it's beneficial and does not contribute to worsening of the condition?
Yeah, I think this goes back to something we've talked about multiple times now, is it's dependent on what the available pain-free range of motion is for the patient. I think using cycling to push through a plateau or a painful area of range of motion is not where it's going to be beneficial. And so to decide when cycling is appropriate, they need to have the range of motion to be able to get all the way around on the bicycle. And I found that going backwards, they need a little bit less range of motion or a little less flexion versus going forwards. And so if they can go around a full cycle going backwards and it's not painful, that's where I'll start. And then if they continue to improve and then are able to go forward revolution without pain, then we can start with that. But it all depends on what their pain response is. Typically, we're seeing about 110 degrees required for a standard upright bicycle that we have in our therapy departments. And so usually getting to around that range of motion. However, once we do start with cycling, we stay with minimal resistance or no resistance on the bike to essentially just get that cyclical range of motion, and get, similar to a CPM, getting many cycles of motion within a short period of time, and then only increasing that resistance when they're not having any further irritation or inflammation that day or the next day, and that they're able to get all the way around with a normal range of motion, normal mechanics, where they're not shifting side to side, which is often where we'll see people kind of trying to compensate. And then I also think there are other devices that are just standalone pedals, not a full cycle, that you can set up for a patient at home or in their office, where they need much less range of motion than the 110 degrees, and that could be an alternative until they're able to get that range of motion of just, again, sticking with pain-free range of motion and getting that entire cycle of motion going.
Thank you. So given the complexity of arthrofibrosis, collaboration with other healthcare providers, such as rheumatologists or pain specialists, is often necessary. Sebastiano, how do you determine when a referral to a specialist is warranted, and how do you coordinate care to ensure comprehensive treatment?
It's the biggest question. It doesn't take 4 minutes, it takes 40 minutes. No, I'll try to be concise. I think if we are talking about the surgeons or the orthopedic specialist here, it's different. Let's say we are progressing throughout PT with either a post-surgical or let's say a patient that had whatever history, multiple surgery, single surgery, doesn't matter, an arthrofibrosis. So we started treating these patients, we're progressing somehow, and after a period of measurable progressions, we see, and so advancements, we see for 4 to 6 weeks that we hit a plateau. So nothing happens, flat land for 4 or 6 weeks. Rarely this is leading anywhere. So the point is, when we see this, and we tell these to patients in advance, hey, if we are going to hit the plateau for more than 4 or 6 weeks, it's the moment in which we need to draw a line and understand if we need someone else help, which might be an orthopedic consultation. But we want to see someone that is skilled in dealing with this pathology, because the problem is, and I'm coming back to your question, we need skills, we need specialization, and we are lacking this. As physios, I mean, in med school, physio school, there is no formal training about the arthrofibrosis. There is no one actually teaching us what to do. So what we try to do is think in advance and create a team. That's what we have done here in Switzerland, which was involving surgeons and telling them, hey, listen, this is not that rare. It's happening. The fact you have seen 1 or 2 patients with stiffness in your career is just because they left. It's just because they, searched for other care or whatever, but they are around. And in literature, if you check, we can talk about 5 to 10% of an incidence. Actually, a solid number is 10%. So this is happening after total knee replacement, ACL, reconstructions, or even basic meniscal surgical procedures. So we need to have them skilled before. Otherwise, when we need them, they cannot help us. Actually, they can harm the patient. They are trying to do their best, but they are too invasive. They try to restore anatomy in the OR. They use the wrong tools, or anyway, they're lacking training. In relation to other health professionals, as you mentioned, such as the rheumatologist or psychologist we mentioned earlier, I think we try to involve them, whoever, let's say the rheumatologist or the psychologist or a nutritionist, whenever we feel it's the case. Nutrition-wise, we have no evidence supporting nutrition to help this patient, but we also know some supplementation can possibly help, or maybe they're just eating in an awful way. We want to have them guided somehow. Rheumatologist, I think, is the lacking figure in the overall process here. I think all of us, we would like to have a rheumatologist, skilled one in the team, and we are often lacking these health professionals. So we would like, it's a dream thing. We would like to involve him or her from the beginning to understand if we are missing something. Is this patient also dealing with something else we are not as an orthopedic surgeon or physical therapist, we are not tracking, we're not detecting, but it's not that easy to have someone on board with skills.
Good. Yeah, unfortunately, we are running out of time. And yeah, so I have to say that this was all for today. So many topics. I think we would have much more to discuss. So who knows, maybe a follow-up meeting could be very helpful. Yeah, so we've come to the end of this expert panel discussion. Thank you, the three of you, a lot for your valuable contributions and for the insightful discussion. And for the viewers at home, thank you for watching. And please help us spread the word and spread awareness. And yeah, thank you so much.